I'm going to give a historical background and rationale for why we would try to do such a crazy thing. This is my various sources of funding. So a little bit about alcoholism. This is Gin Lane, which is a couple hundred years ago, but things haven't changed that much. Just to summarize some of the reasons that we should be concerned about alcoholism, the kind of cardinal feature of addiction is compulsive use regardless of consequences. This loss of control and inability to stop or to control the amount of consumption. The consequences are manifold and severe. The effects on people's physical health, leading to death, mental illness, violence and crime, economic consequences. Ultimately, how this affects the person and how they live their life. Addiction can affect people's their values and just how they live their life and their self-respect and their integrity in a way that is incredibly damaging and harmful. And so there are treatments available for addiction, but there's a need for much more work to be able to help people out of this morass that they find themselves in. A little bit of historical background about the relationship between addiction and religious experience and mystical experience in particular. The relationship has been something that has been written about a great deal over certainly at least the last couple of centuries. William James, in his Varieties of Religious Experience, wrote a lot about conversion experiences that people had, sudden epiphanies, life-changing events that altered their religious perspective, but also frequently would result in lasting change in behavior. He's famous for this phrase, the only cure for dipsomania, meaning alcoholism, is religiomania, that people would have a religious experience and completely change their outlook. Carl Jung saw addiction in some ways as a misguided spiritual quest for unity, for meaning, for connection with God or with the spiritual world. He also felt that for really severely addicted people, the only hope in some cases was some kind of spiritual awakening. The Oxford group was an evangelical Christian group active in the 1930s who developed a program to attempt to save or rescue alcoholic people through a process of religious conversion in a Christian context. And really indirectly, the AA movement emerged from that as a less doctrinaire, not explicitly Christian or religious movement, but one that very basically focuses on the need for spiritual connection and reliance on a higher power for a person to recover from their addiction. And so Bill Wilson was the founder of AA. And this is an interesting backstory. Most people aren't aware of the historical relationship between psychedelics and actually the founding of AA. When Bill W. became sober, he had this famous spiritual awakening experience while he was undergoing detoxification at Towns Hospital here in New York. People were prescribed relatively high doses of these belladonna alkaloids, which are deliriants and can produce certainly a hallucinatory and in some cases a psychedelic experience. It's not known whether that's actually what was going on when he had this experience, but he did have this very striking awakening experience, and I'll read you a brief description of how he described this. What happened next was electric. Suddenly, my room blazed with an indescribably white light. I was seized with an ecstasy beyond description. Then, seen in the mind's eye, there was a mountain. I stood upon its summit where a great wind blew, a wind not of air, but of spirit. In great, clean strength, it blew right through me. Then came the blazing thought, you are a free man. So that was his experience, which may or may not have been drug-induced, which led him to abstain from alcohol for the rest of his life and go on to found AA. In 1956, Bill W. was curious about what he had heard about LSD treatment, and he had a LSD experience at the LAVA with Sidney Cohen and Gerald Hurd, and he believed that he had the same experience of connection with God, and he strongly believed that LSD could be a very useful tool within the context of AA to help people who are having trouble establishing a spiritual life to get that spiritual experience and be able to get sober. And he was unable to persuade the AA board of this, and it did not become part of the AA program, but that was his wish. Another sort of indirect form of evidence is the very low rates of drug and alcohol use disorders in people who are active members of religious groups that use psychedelics as sacraments. And particularly this is known to be the case in members of some of the ayahuasca-using religions, the União do Vegetal and Santo Daime in particular, which are founded in Brazil but worldwide now. And also in the Native American church, which uses peyote as a sacrament. And so this is not the strongest kind of evidence because clearly there are religious beliefs and practices and norms of behavior involved in addition to the effects of the plant medicines. But it's still striking how low the rates of active substance use are in these groups. LSD was really discovered by Albert Hofmann during the Second World War, and very soon thereafter was the subject of a lot of interest and scientific work to understand its effects and to figure out what its clinical utility might be. And one of the first indications for this that was looked at for LSD was the treatment of alcoholism. And as early as 1953, LSD was being used clinically within programs, not just in research studies, in Saskatchewan, using what came to be known as the psychedelic model. And that means that people going through these inpatient programs primarily were carefully prepared for an intense experience, then given one or very few sessions of treatment with a relatively high dose of LSD from maybe 250 to 500, 600 micrograms, high dose LSD psychedelic experience. And then the model really was that this peak psychedelic experience would allow these people to reorganize their personalities, reorganize their lives, and have lasting change, and as part of that, recovery from their alcoholism. And there were many publications, at least 30 publications of uncontrolled reports, many of them showing outstandingly good clinical outcomes in what were very refractory populations of inpatient, repeatedly hospitalized alcoholics. There were controlled trials, and I'll tell you more about that in a moment, but at the time, they were relatively small trials. The results were inconclusive. And then in the early 1970s, after the kind of cultural upheaval that was going on and the Controlled Substance Act, which was passed in 1970, the whole enterprise of research on psychedelics, human research on psychedelics, came to a crashing halt. It was a scary time for many people. It wasn't clear where things were headed, and there were a lot of people that really thought that LSD was going to kind of destroy the society as we knew it. And there were some pretty profound changes going on. So it could take guys like this, Timothy Leary and Dick Albert, back in early 1960s at Harvard. Albert is, a young assistant professor trying to get tenure. Leary's a well-respected psychologist. A few years later, this is what's going on. And I don't mean to pick on Tim Leary, but people were hearing about Charlie Manson. Here's Jerry Garcia, who's a good guy. Ram Dass, who looks a lot different from the previous picture too. It's just important for us to remember what happened and how LSD got the reputation that it has and make sure that we don't do anything to fan the flames of that kind of sentiment. The whole enterprise came to a crashing end, and that was it, at least until the 1990s when a little bit of research finally started to happen again. But going back to the studies that were done, what did the data show? This is a meta-analysis that was published just 3 years ago in 2012 by Terry Krebs and Paul Johansson, summarizing the results of the 6 randomized controlled trials of LSD-assisted treatment of alcoholism that were conducted. All of them used single-session high-dose LSD, mostly male inpatient alcoholics, very severe population, and they were different in a number of other respects in terms of, some of them were done by people who were really committed to the psychedelic model, others were more trying to show that it didn't work, and there were really polarized opinion back then as well. But what this showed was that across the board, these are the estimated effects and confidence intervals. And this here is when you pool the 6 studies together, you get an odds ratio of about almost 2, which means that the LSD-treated people were, well, not quite 2 times, but much more likely to remain abstinent or problem-free with their drinking. And this effect is larger than the effect of any currently clinically approved treatment for medication treatment for alcoholism. So these are old studies, it's a meta-analysis, but still it's the kind of thing that would, you would hope would stimulate interest in this topic of research. So how would this work? I mean, how would a single session of treatment with a drug produce lasting changes in behavior? This is kind of a summary model that we put together. It's nothing really fancy, but it just kind of outlines a lot of the possible pathways. So we start with drug, person, or set, and setting, all of the variables that kind of go into the situation. And then there are, of course, acute effects of the medication. And we can think about biological effects, the direct effects on the serotonin receptors, secondary brain effects, glutamate receptors and some intracellular signaling pathways are stimulated almost immediately. And then on the psychological side, there are these transformative, mystical experiences, but also cathartic emotional experiences, profound insight, and a variety of psychological experiences that people can find extremely valuable. And then, of course, if this is going to make any change in the long run, there have to be persisting effects. So again, on the biological side, there are certainly models that would explain how there could be neuroplasticity, changes in connections between neurons and pathways of brain activity being emphasized or de-emphasized, just changed organization of brain function, essentially. Mood and anxiety could potentially improve. There's some evidence for that. Even changes in personality, which seems kind of remarkable for a single experience, but there is some evidence for that as well. And then changes in beliefs and values, which would motivate a person's change in behavior. And then for a lasting change, these are some mechanisms that are known to be highly predictive of change in drinking behavior. So decreased craving, enhanced self-efficacy, which is the confidence of being able to change, a sort of I think I can feeling, and increased motivation to change. And then all of these things could potentially lead to decrease in alcohol or other substance use. So those are some of the pathways that we're interested in exploring in our work. So moving on to the actual pilot study that we did. This study was published earlier this year in the Journal of Psychopharmacology. And this was a small single group study, so that means no control group. Everyone received active psilocybin. And everyone received 12 weeks of psychosocial treatment or therapy, which included both a component that was geared towards addiction treatment, evidence-based addiction treatment based on motivational interviewing, and a component that was focused on preparing for supporting during and debriefing, processing, integrating after the psychedelic experience. So there were 12 weeks of therapy, and in that context, there were 2 psilocybin sessions, one 4 weeks into the treatment, and the second one 8 weeks into the treatment. And the doses we used were 0.3 and 0.4 milligrams per kilogram, and that would be, for a 70-kilogram person, that would be 21 or 28 milligrams of psilocybin, which are pretty strong, pretty high doses. We were interested in this pilot study, first of all, just to see how the alcoholic patients responded to the psilocybin, to demonstrate the feasibility of this model, just to show that we could do it, and then to evaluate the changes in drinking. And this is, we can't prove efficacy on the basis of a non-controlled trial, but we can, if people are improving a great deal, that would be better than if they were drinking more after the psilocybin. And then also we wanted to look at some of these psychological intervening variables, other forms of change that we thought could potentially contribute to the changes in drinking behavior that we'd want to observe later on. There were 10 participants. They were about 40 years old on average, and they'd been drinking alcoholically for about 15 years. They were moderately severe overall, 6 men and 4 women. 8 of them had at least some evidence of physical dependence or at least high tolerance. All 10 of them received the first psilocybin session. 3 of them did not receive the second session for various reasons, but 9 of them completed all of the follow-ups, and so we have complete data for 9 out of the 10. The blue is percent drinking days. So how many days out of the last month, what percentage of the days did you drink? And the red is heavy drinking days, which would be 5 drinks or more for a man, 4 or more for a woman. And this is a baseline, so they were drinking a little less than half of the days. After 4 weeks, they'd been receiving the psychosocial treatment, the counseling, and they dropped a little bit. After the first psilocybin session, there's this large drop, which then is pretty much sustained. The last follow-up point was 36 weeks, so that's 9 months from when they began, or about 8 months after they had the first psilocybin session. They improved considerably, and those improvements were maintained over time. So that was good news. And these effect sizes, if you look at the difference between here and here, these are large effect sizes, statistically speaking, which, you know, again, encourages us and makes us think that we're dealing with something that's robust and real. These are correlations. I wanted to show you some of the work we did to look at potential mechanisms, why this is working for people. Across the board, there were strong correlations between the intensity of the experience that the person had and the mystical quality of the experience that the person had, and all of the positive outcomes that we would want to see. So this is the drinking outcome correlated with intensity. Down here are the people who got a lot better. They're the people who had much higher scores on this measure of intensity of experience. And it's a pretty strong linear relationship, correlation coefficient of almost 0.9. So this is correlation between mystical experience and craving. Not quite as impressive, but it's a correlation of greater than 0.8. Stronger mystical experience, greater decrease in craving. And then we also looked at self-efficacy, which is that I think I can feeling, and again, a statistically significant correlation, stronger mystical experience, greater improvement in self-efficacy. Anecdotally, one of the interesting things in this study was that there was a wide range in the intensity of experience that people had. And a couple of participants really had very mild experiences on these high doses of psilocybin. Others had, very strong experiences. And, some of the experiences were blissful, some were much more challenging. And but overall, in the outcome, when we talked to people, weeks and months afterwards, a number of people talked about the importance of feelings of forgiveness, self-forgiveness in particular, and love, or being loved and feeling whole in the changes that they were able to make. Feelings of rejuvenation and optimism were prominent, and decreasing craving for alcohol, especially right after the session. People just seemed to have no interest in alcohol at all, and that the craving did tend to come back after time. And then increased commitment to positive values. It's just striking again and again how the kind of pro-social language that you hear from people. It's really, this is kind of mom and apple pie stuff. You want to be, help society, be there for my family, contribute, be more active in my church. I mean, it's hard to see why anybody would worry about these kinds of effects. But I think we've showed definitively that you can do this. You can use psilocybin in this model. There were no significant adverse effects at all that persisted beyond a mild headache or some transient anxiety. And the people did improve a lot in ways that we would hope that they would. And there was this correlation between the intensity and mystical quality of the experience and how much they improved. So we're currently conducting a double-blind study, which we started at the University of New Mexico and recently, just in the last few months, launched at NYU. And ultimately, we will recruit 180 participants for this study to really rigorously test the efficacy of this model. And we're also going to be doing an ancillary neuroimaging study using fMRI to look at changes in functional brain activity at rest and in response to alcohol cues and emotional stimuli that persist the day after the session, and whether those predict positive change in drinking. This is a Gartner hype curve, and it's not a scientific thing. It's from marketing and technology adoption. It's considered to be a typical cycle that when a new innovative product or methodology comes out, the initial reaction is kind of ecstatic, and people think this is going to do amazing things. So they're inflated expectations. And then it turns out that, it's not quite as great as people thought it might have been. And there's this disillusionment, the trough of disillusionment. And then gradually people come back to a more realistic balance. I'm hoping that in this work we're now working our way up the slope of enlightenment towards the plateau of productivity. So I just wanted to acknowledge some of my colleagues at UNM and NYU and other centers that have been involved in this work, and the Hefter Research Institute, and as well as Carrie and Claudia Turnbull, who've provided a great deal of funding for this work, and I'm grateful to all of them, and thank you very much. It's challenging because there's really no condition that causes, there's nothing we could do that would cause an experience identical to that of psilocybin, and we would be confident that it would not be therapeutic. And there aren't really even things that, it's hard to come up with something that's even a credible control. So people have used different kinds of medications, stimulants, sedative drugs, low doses of the psychedelic you can do, and then you can say, you're definitely going to get psilocybin, and maybe you'll have, if you have a big experience, you have a big experience, and if you don't, you don't. And it's also tricky because we really believe that the subjective experience is inherent in the beneficial effects of these medications. So it's like if you had an antibiotic that treated pneumonia and it happened to turn people's skin blue, you wouldn't be able to do a blinded study. Well, maybe you could use some special glasses or something. But it would be very hard to do a double-blind study. So does that mean, I'm sorry, we can't, I know you're dying of pneumonia, but we can't treat you with this. We haven't been able to do an adequately controlled double-blind study. So it's not the drug's fault that this is a problem, but it is methodologically tricky. And the placebo effects, ideally, we would want the placebo effect to be the same in both groups. And so that's if the psilocybin group is doing better, it's because the drug is really doing something. So we try to manage expectancies around this, both by encouraging people, no matter what kind of an experience you have, try to make meaning out of it and get whatever you can out of it. And we also tell people truthfully, you could get psilocybin and have a really boring experience. And you could get a control medication and you might have a mystical experience. People have had mystical experiences on placebo or controlled medication. So I think we can truthfully say that. But we try to minimize what you don't want to happen is the person says, if I get psilocybin, I'll stop drinking, and if I don't, I won't. Okay, I know I got psilocybin, okay, I'll stop drinking, because that's not the mechanism that we're really interested in. But we spent hours and hours and hours talking about these questions, and there aren't any perfect answers. But I mean, ideally, you want your control condition should be some kind of psychoactive medication. People feel something, and at least it's possible for them to think about that as something that might be therapeutic. Our primary outcome was % heavy drinking days, which is a standard outcome that's used in alcohol treatment trials. And the reason is that, we do believe that for most people who have become dependent on alcohol, that you would classify as having alcoholism, it's not a good bet for them to return to controlled drinking. I mean, you can't say that nobody's going to be able to do that, but the odds are definitely against them if they try to do that. Now, maybe after psilocybin it's different, but we're certainly not assuming that. But the fact is that in most treatment studies, there are some people who become completely abstinent, and there are some people who don't change at all, and there's a lot of other people that improve some. And so that's good too. So we don't want to, I've never believed in, considering treatment a failure if somebody ever has a single drink. If they don't, that's ideal. But if they do, then if they've improved, and we'll hope they will continue to improve. So we had, in the pilot study, we had people with variable periods of abstinence, some people who were completely abstinent for the duration, some people who, a couple of people really didn't improve, and a bunch of others who might have had a slip here or there, and continued to be doing better by the time we got to the end of the study. So my guess is that if you look at a categorical outcome, no drinks ever, you'll see these rather steep curves where people do relapse or at least slip, and that we would see a similar separation between the groups. But it makes the outcomes look worse, because the total abstinence rate it's the highest possible bar for success you could have, and so that's just not how we've typically done the studies. That is the way FDA usually tends to want. The FDA, when they approve a drug for alcoholism, they're primarily interested in the total abstinence outcome. So we'll collect those data as well. We would exclude, I think any of the groups currently doing research with psilocybin would exclude people with bipolar disorder or a psychotic illness. Depression is a little bit different. We excluded people who had full major depressive episode, because it's a different thing. And there's a lot of interest in psilocybin now as a treatment for depression, and that's another thing to look at. But having the two conditions together kind of complicates the analysis, and you don't know, why people are improving if that's happening. So several people in the pilot study and in our ongoing study now have had histories of major depression and some degree of depressive symptoms, and quite a few of them have anxiety disorders. So, but no, we haven't attempted to treat people with kind of more severe co-occurring disorders in addition to the alcohol. We have a team of 2 co-therapists. I was present for all those sessions and quite a few of the ones that we've done in the double-blind so far. And I have to say categorically, it's the most rewarding clinical work that I've ever done. To see the kinds of transformation and the ability to get to really core issues in people's lives and issues of meaning and existential questions that they're struggling with, which, it's not that easy to get there with traditional psychotherapy. And it's just really been a privilege to go through this process with some of these people, and and witness, and these are people who are really suffering from alcoholism too, and to witness the courage with which people confront, the most painful issues in their lives and the most, the most difficult things that they could possibly confront in order to lead a better life, to have a better life. No, I would not say there were any stark contrasts. Anything that I did say might sound like I was indulging in gender stereotypes, so I'm not going to say it. But there's, some people are a lot more psychologically minded than others, and some people might believe that we should be selecting patients on the basis of their capacity for introspection, and that they would be kind of more able to make meaning out of these experiences. But no, not on a gender level, and not really on a personality level either. I'm not sure I see any, even patterns in the tea leaves as far as like how do I know if this person is going to benefit or not? The only thing I would say is we had, there've been one or two people where you just didn't feel that you had the real strong therapeutic alliance, or that the person was being really completely genuine and open. And I think that's a bad sign. But that's an N of 2.